to know who Lakeview Health is, and we're a health and wellness and life and balance treatment program for addiction. And these are some of our core beliefs that are on the slide about servant leadership. We support and empower our staff to act as a tool for the families and individuals struggling with chaos and pain. We're, as I said, a residential adult treatment program in Jacksonville, Florida, ready to help you and your clients recover from mental health and substance use disorder. We invite you to learn more about us by visiting our website at lakeviewhealth.com. So we want you to please be sure to complete the online evaluation at the end of the presentation in order to receive your certificate of completion. All certificates will be emailed to you. If you have other staff or individuals who are watching who did not register, we will need you to contact Donna Mahacek at DMAHACEK@lakeviewhealth.com, and your certificate will be sent to you. So I want to give a special thanks to Coastal Spine and Pain today. They are generous enough to loan us Dr. Hunt today. And I want to point out there's a question dialog box over in the right. So if you have a question or concern, please use that to notify us that you have a question. And this is Dr. Hunt's bio. I don't know if you want me to read this. You guys want to read it really quickly, but we're very fortunate to have him with us today. And we'll go ahead and let Dr. Hunt get started. So welcome, Dr. Hunt.
Thank you, Katie. As she said, I'm Dr. John Hunt. I'm got boards in anesthesiology, addiction medicine, and pain medicine. I've been doing exclusively pain medicine since 1998 and addiction medicine and pain medicine since 2000 after I completed my fellowship in addiction medicine. I work for Coastal Spine and Pain Center, which is a large pain group in Jacksonville, Florida. We have about 8 different locations and about 15 different pain docs. We see many different patients, and I am tasked largely with taking care of the patients that have issues with both pain and problems with their drug use. As we all know, we are immersed in a huge opiate crisis which has reached pandemic proportions. According to the CDC, we killed about 35,000 people through drug overdoses in the last available year for statistics, and we're on track for about a 50,000 a year death rate now, which is about 1 person every 12 minutes. These drug overdoses don't involve only things like heroin, but often involve prescription medications, largely involve prescription medicines, as a matter of fact, especially when combined with medications such as alcohol, benzodiazepines, other CNS suppressants. In this context, I think it's important to remember that drug use is normal, acceptable human behavior. We have knowledge of many different societies, and all of them have had a socially acceptable mind-altering drug with prescriptions for its use and proscriptions against abuse. In the United States, our legally socially acceptable drugs are tobacco and alcohol, and from a societal point of view, cannabinoids are becoming much more prevalent and acceptable, so that's basically what we use socially. The problem with providing a mind-altering drug such as opiates on a large population basis is that becomes a socially acceptable, medically provided mind-altering drug, and we have reaped what we might call the unintended consequences of that, the particular massive experimentation. This began in the early 90s. There was a perfect storm of 3 things that occurred. We had an upswing in patient advocacy for a very real medical problem of chronic, poorly treated pain. We then had Big Pharma came in and manipulated the system and started, in some ways, persuaded the medical community to change their previously held beliefs that opiates should be only used on a short-term basis by promoting the use of extended release opiates with the incorrect belief that if you were treating pain, you would not produce unacceptable consequences such as addiction. This was not true. The medical community bought into this, and many of us drank the Kool-Aid, as it were, and for many years we've been providing large amounts of opiates for chronic non-malignant pain, and we have created a large population of patients that are suffering from adverse consequences as a result of that. The essential problem here is that it turns out that after we've been providing these opiates for the last 25 years, we have pretty much found out that opiates are effective for short-term pain, but when you use opiates for chronic non-malignant pain, you produce a large number of problems and medical consequences. The one that we are most familiar with is addiction, and that's the one that gets most of the press because the addicted folks tend to be the ones that die of heroin overdoses and are most visible, but they are only the tip of the iceberg. The real problem, and in my estimation, the true elephant in the living room, is the fact that of all the millions of people that we have given chronic opiates to, perhaps only 20% of them become truly addicted, and the other 80% are tolerant and physically dependent and are suffering significant side effects of the drugs, even though they are not truly addicted, close quote. Those of you who are listening to me that are in the addiction field understand that addiction is characterized by the 4 C's of compulsive behavior, cravings, loss of control, and most importantly, continued use despite harm. But we also have significant side effects which are also significantly impacting the problem. As a quick review, we understand that all drugs have side effects and complications. A complication is something that requires the drug to be discontinued because the drug itself is causing a problem, such as, say, a bleeding ulcer from the use of aspirin. A side effect would be something like heartburn from that same aspirin dose, which could be treated with an antacid. The problem that we have when we're dealing with people that are taking chronic opioids is that people confuse 2 important side effects with addiction, and often this is not the case, and those 2 side effects are tolerance and physical dependence. We did not really understand, I don't think, how important those 2 side effects would be in terms of causing these medications to produce significant problems and consequences. And as we all know, that if you give opiates at a certain dose, after a while, a person will become tolerant, and that dose will become relatively ineffective. And if the person tries to discontinue the medication abruptly, they will suffer from withdrawal, which is the physical dependence aspect. So we have tolerance and physical dependence in all of our patients taking opiates, and we have many, many patients out there that are in a position where they're taking opiates only to prevent withdrawal, and the opiates are no longer effective for treating pain, and nobody's willing to give them more opiates because of to make that dose more effective, and that's the only way to do it, right? Is to give them more opiates to make them more effective, because of the new CDC guidelines that have come down the road. This whole system, this whole problem has been exacerbated by the fact that we in medicine are in a service industry. We provide a service to our patients. Our patients can be seen as our customers. if you're going to have a successful practice from a financial point of view, what you want to have is happy customers that come back and see you again and give you more money. The way that that can be done is give the customer what they want, which in this case can often be opiates. I think only a small percentage of my colleagues in the pain field actually provide medications on that basis, but it is an insidious and kind of underlying factor that exacerbates and perpetuates the use of opiates, because you want to have your patients be happy with you. You don't want, people do not deal with confrontation well. And in severe circumstances, you know, we had for a period of time in the early 90s and late 90s and early 2000s especially, we had the rise of the pill mills here in South Florida because of the fact that you can make lots of money selling drugs, and people understood that you could sell opioids, especially oxycodone, in large quantities and make a lot of money. There's an interesting book called, quote, American Pain, close quote, that lays out how that all came about. It's interesting and kind of somewhat scary reading, actually. At any rate, the government has stepped in to try and regulate pill mills, and we have a lot of different regulations that are to try and address this issue, and the CDC has come out with the guidelines that we're looking at here to assess risk and addressing the harm associated with opiates, and they're talking about when to initiate and continue the opiates for the reduction of pain, how to select opiates, how to regulate the dosage, the duration that should be used, how to follow up patients, and how to discontinue medications. These guidelines are useful for patients that have never been started on opiates. They're significantly less useful for patients that are already on opiates. The government has also stepped in and restricted the supply through the pharmacy supply system, and also various government agencies are strongly encouraging, I might say, us pain physicians to reduce the amount of opiates that we prescribe. And this has caused a lot of primary care level providers to just stop prescribing opiates, throwing their patients kind of into the pain clinics and onto the emergency medicine system for their opiates. The supply limitations are also causing problems with people obtaining opiates, and the end result of this are two things. Number one, I think they're primary contributors to the heroin epidemic, because heroins have now become much more available and much cheaper than oxycodone. Now, a person that is addicted to a drug, as a general rule, will strongly prefer a drug that whose dose they know and whose effect they will know. The addicts that I've treated strongly prefer using oxycodone 30 milligram immediate release to obtaining a glassine packet of unknown white powder from their friendly neighborhood heroin dealer. But if they can't get the oxycodone, they will go for the heroin, and this is where we're getting a lot more heroin use, and the sharp spike in deaths because of the unpredictable nature of those drugs. We also are creating a problem that is termed pseudo-addiction in the medical community, which is when a person is no longer able to find their drugs, even though they may not be truly addicted, in order to avoid withdrawal and to maintain relief of their pain, they will start exhibiting behavior typically associated with addiction, i.e. obtaining drugs on the street, using other people's drugs, going to the emergency room frequently, overusing their medications, etc., etc. And it becomes quite difficult to sort out which patient belongs in which category, whether a patient is pseudo-addicted and which patient is addicted. That's largely my excuse me, my role in Coastal Spine and Pain Center is to evaluate the patients who have exhibited behaviors that are worrisome and to determine what the underlying problem is and come up with a treatment plan that addresses their medical situation in kind of a global sense. Often in pain clinics, when a patient becomes non-compliant, they just get chucked over the side and told to go to rehab, close quote. And when they go to rehab, the rehab tells them to they need to stop using those nasty drugs because that's the problem. In the first case, when they discontinue their pain medications and send them to rehab, that doesn't take care of the pain problem. It does take care of the drug problem. When they go to rehab, they get the drug problem taken care of, but not the pain problem. So the issue is trying to deal with both problems in a rational basis without destabilizing either one. I'm sort of referred to as the principal's office where these problem children get sent. And my function largely is to clarify what's going on. You know, the first thing that happens when I see these patients is I need to review their history, and my colleagues in Coastal Spine and Pain are pretty good at giving me a history of what their concerns are, and whether that's overuse of drugs, noncompliance, illicit drugs, use of alcohol, unprescribed medications, et cetera, and from that evaluation, which includes the history, the physical examination, interview of the patient, a comprehensive drug and alcohol history, I generate a differential diagnosis, which largely includes, number one, whether they have inadequately treated pain, i.e. pseudo-addiction. Number two, whether they have an addiction, or other factors such as whether they're just unaware of the boundaries that are involved in the use of drugs. Again, as I said earlier, people live in a world where they use drugs and alcohol on a regular basis. Many of my patients live in a social environment where the use of cocaine is a normal and acceptable thing. Many of them live in a world where alcohol is a normal and acceptable thing. Most people live in that world. Many people have colleagues or friends in themselves. They use marijuana on a regular basis, and they have to understand that if they're going to be prescribed opiate pain medications, they have to be willing to modify their behavior, and in order to get them to modify their behavior, they have to be told in the first place what the concerns are, what the expectations are, and what the boundaries are. This often does not happen in a doctor's office. Doctors are not really good about doing this, and it's one of the major problems that I deal with when I get a patient into my office, because they said, I didn't know that I wasn't supposed to drink when I was using alcohol or using narcotics. I didn't know that they would get upset with me if I continued to smoke marijuana or use cocaine, because that's just normal stuff for where I live. Some patients come from an environment where those boundaries are set, but they're not enforced properly. Other patients are just willfully disobedient. And they said, well, I'm just going to do what I'm going to do no matter what. Even though I know what the boundaries are, I'm just going to take my medications like I want to, and I'm going to continue to use other drugs even though that is not acceptable behavior. So we have at Coastal Spine and Pain established protocols that try and clearly establish our expectations, clearly establish the treatment plan that that patient is going to be provided, and clearly have the patient understand what their responsibilities are in terms of what they need to do in order to stay within our boundaries and continue to be an acceptable patient and an appropriate candidate for the continued use of opiate pain medications. That involves a fairly extensive variety of screening tools. The primary one I think that we use, or one of the primary ones, is drug screening. Drug screening is something that needs to be done on an organized and rational basis. In our clinic, we have what I call the no pee, no see policy. If they don't pee in the cup, they don't get seen. So they understand that whenever they come in to see me, they're going to have to provide a urine or a saliva sample in order to be seen. We have pretty strict environment in terms of our collection procedures because the patient has to have a significant degree of confidence that the drug screen sample that we send to the lab is actually that person's drug screen and that the results they get back belong to that patient. It doesn't work very well if you have your typical primary care practice where at least at my primary care physician, the way you give a urine sample is they hand you a cup, they hand you a magic marker, you write your name on the cup, you go in there, you pee in the cup, and then you put it in this little pass-through location where it sits there with 20 or 30 other drug screening samples, unmonitored and unlabeled until somebody gets around to it. There's a lot of potential for abuse and misuse under those circumstances, and we take considerable steps to make sure that the patient comes out, hands us the cup, we do the temperature test, we put a top on it, we put a label on it, we seal it with tamper-proof tape, and the patient knows that that sample is it's not a chain of custody sample, but it gives them a high degree of confidence and me a high degree of confidence that when that result comes back, if that sample has something in it that shouldn't be there, it's because that patient handed me that sample when they came out the door. As we all know, there's lots of different ways to mess with the system. I mean, people come in, they try and substitute urines. I'm not telling anybody out there in the addiction biz anything that they don't know. They can contaminate the sample, et cetera, et cetera. But we do on-site testing, and then we send many of our samples off for confirmation testing depending on what the risk evaluation for that patient is, whether we feel that we need to do a comprehensive evaluation of the contents of that drug screen for metabolites and for other drugs. So that's one of the things that we use. We also use pill counts. A patient is expected to bring in their pill counts. We schedule patients a week ahead of time so they have medications left over. We assess them on a very regular basis, and they understand that in our clinic, compliance is not an option. They need to comply with our rules and regulations if they expect to continue to receive controlled substances from this clinic. Now, that works reasonably well for patients that are not addicted. The addicted patient is a different problem, obviously. Then you need to go to Plan B in terms of providing a different treatment paradigm for them. Many of the patients that come into my clinic, especially the patients that have never been through treatment, that have been identified as being non-compliant or using illegal drugs or whatnot. Many of them have never been through drug rehab, have never really been confronted with their drug-using behavior, and they really don't understand the role that the drugs are playing in the chaos in their lives. They associate their problem with pain, not with the use of the drugs that they're misusing to treat the pain. And that is a fact of life. There is nobody that I have ever met that went to their high school guidance counselor and said, I want to be a drug addict when I grow up, because all drug addiction starts with that first exposure to the drugs. And in most cases, and in almost all cases, that happens under a circumstance where the drug use seemed to be reasonable at the time. Somebody goes to a party, they get handed a beer to try for the first time. Somebody hands them a pill and says, try this, it'll make you feel good. They go to a doctor because they sprained their ankle, they get given a prescription for hydrocodone. None of these behaviors are intended by that person to begin an addictive process, but they end up doing it because in a certain percentage of patients that are exposed to the drug, a part of their brain that they're not in contact with gets hijacked by the drugs. That happens in about 20% of the patients that are exposed to any mind-altering drug, and that number is pretty constant, whether it be opiates or benzodiazepines or alcohol, or, as becoming more and more apparent, cannabinoids, or THC at any rate. And those patients to whom that happens, their subconscious brain reacts significantly different to that exposure to the drug than a non-addicted person. And it happens, as we all are aware, in the subconscious mind. And that's a primitive part of our brain, which you could call the lizard brain, because it looks pretty much like a reptilian brain. And the subconscious brain works very differently from the conscious part of our brain, our evolved brain, or our monkey brain. The lizard brain, the subconscious brain, is involved with basic messages of comfort and discomfort. It knows when things are causing it discomfort, and it sends a message to the conscious brain that the conscious brain needs to produce a behavior that eliminates that discomfort, fight or flight, as it were. Or in other cases, it has positive benefits. Anybody that has a child understands that they are bonded to that child, and the reason they're bonded is their subconscious brain is telling their conscious brain to love, care, protect, and defend that child no matter what the circumstances. And that is not consistent with personal survival, but it is consistent with species survival, and that's probably why it's there. But the point being is the person that is addicted, when they expose their brain to that addicting drug, for the first time, that little lizard that's they're born with, that little echo that they're born with, starts to change into something quite different, because the addicted person starts using the drugs to reduce discomfort, whether it be emotional discomfort, physical discomfort, social discomfort, and that response becomes more and more prevalent. And that little gecko they were born with changes to a Gila monster. They have to avoid the rock. It changes to an alligator. They have to remember where the swamp is. And then it changes into a Komodo dragon, chasing them around all the time, taking up more and more of their time. And a person at the end stages of addiction is functionally locked in a dragon's cave with a fire-breathing dragon saying, use. And that's their only response to most problems, even though their conscious brain, their monkey brain, is saying, this is stupid, got to do something else. And that's the analogy that I use to try and explain to my patients why this happens to them, and many of them were baffled as to why they've got this problem. Why can they not just say no, like Nancy Reagan told them to 40 years ago, right? Well, it's because their subconscious brain has been hijacked, and they need to develop a new set of skills in order to deal with that problem. And if I have a patient who has a comorbid pain problem as well as an addiction problem, and I take away their pain medication, and expose them to this pain, if I don't treat the pain problem adequately while I'm treating the addiction problem, they're just going to relapse, and they do. So I have to come up with a plan that will treat both of the problems in conjunction and treat them without destabilizing either one. Okay, so I need to keep the patient in treatment. I need to have an accurate assessment of what the problem is. Is it addiction? Is it pseudo-addiction? Is it willful disregard of rules? Whatever it is, I need to address that issue appropriately. Now, when I am treating people that have a substance use disorder and a pain disorder, it's convenient that I have a very useful medication available to me called buprenorphine. It comes in various formulations. It comes as Suboxone, Subzol, Bunavail, Belbuca, Subutex, and various generic formulations. And the advantage to use of buprenorphine is it's an excellent pain medication. It's actually 20 to 30 times more potent than morphine on a milligram per milligram basis. But it does have significant problems when you're trying to get a patient on that medication. The first one that I run into is it's very minimally euphorogenic, and people associate euphoria with pain relief. All these standard standard pain medications that we have out there, morphine, hydrocodone, oxycodone, have significant euphorogenesis associated with them. That's not true for buprenorphine. And people have to learn how to appreciate pain relief without euphoria. That can be difficult. Other problems that are associated with buprenorphine for the treatment of pain are cost barriers. Frequently, the buprenorphine products are not paid for by the various pharmacy benefit programs for the treatment of pain. And I have a choice of either giving them an addiction diagnosis or having the patient pay for it themselves, and they're fairly expensive. It'd be much more beneficial if these patients were able to get the medications as a tier 2 or a tier 3 drug. And I think that's something that we as pain and addiction communities need to push for. There's problems with indications. The buprenorphine and naloxone products are indicated only for addiction, and you can be used off-label for pain. There's education barriers. Not only the patients need to be educated regarding the use of buprenorphine from a point of view that it is an effective pain medication and not just for addiction, but that same paradigm and same educational problem applies to our medical community as well. There's also significant considerations for diversions and concern for diversion because buprenorphine turns out to be an excellent medication for treating dope sickness in our addicted population. When people can't score their drugs, they use buprenorphine as a rescue drug until they can get their drug of choice. I think the pharmacodynamics and pharmacokinetics of buprenorphine and the way that particularly works is outside the scope of this presentation, but I'd be able to address it if anybody's interested at the end of the meeting of this discussion. But in any case, I think that if buprenorphine were to become available as a pain medication for indication for pain and people were properly educated, it would be a medication that would then significantly revolutionize the treatment of pain here in the United States and help ameliorate many of the problems associated with chronic opioid use that we've discussed previously in this discussion. It's not a perfect drug by any means, but it's much less problematic in many ways than our standard opiates. In any case, when we have a patient coming into our clinic who is on opiates and who has pain, if you have a person who is not on opiates, I strongly recommend that you don't put them on opiates in the first place until you've exhausted all other means, and even then you need to be very, very cautious and very, very circumspect in terms of using opiates for chronic pain. For patient, and I also suggest that you use a very well-developed and specific treatment agreement to establish the boundaries and that your patient be counseled specifically in terms of the boundaries. If you're going to use drug screening, you need to know what you're doing, you need to establish it, and you need to use it on a logical and coherent basis and as a tool for confirming use and addiction. You would be surprised at how many people will mess with a drug screen, even though they know that they're supposed to be, even though they know that they're coming in on that day. I don't call people in for random drug screens, but you'd be surprised at how many people try and run abnormal drug screens past me, even though they know that we're looking very hard at them. And in your standard practice, the number of patients that are being non-compliant is very significant and people need to be aware of them. This is where the SBIRT comes into practice. That stands for Screening, Brief Intervention, and Referral to Treatment. And what we need to do when we're dealing with patients that are on these problematic drugs, opioids, benzodiazepines, people that drink alcohol to excess, we need to be aware of the warning signs, the factors that raise concerns, whether it be overuse, misuse, multiple physicians providing medications, frequent visits to the emergency room, illegal drugs use, heavy alcohol use, whatever. And we need to be willing to address that issue when we see the patient. And the key here is that in most cases, you're not going to make the diagnosis and refer the patient to treatment at the first visit. I mean, there are cases where when somebody comes in, they're a heroin addict with needle tracks up and down both arms, the diagnosis is pretty clear. But in most cases, in most of my patients, what I do is I find out what the problem is. I talk to them about the risk factors that are associated with it. I talk to them about what they have done that raised the concerns and what they need to do to modify their behaviors in order to address those concerns. And then, in most cases, I will give them at least some portion of their pain medication back, and I will use my primary diagnostic tool, which is serial observation. And that fits right into the SBIRT, because every time they come in, I'm screening them as needed. I talk about what the problem is that I see, and if the problem becomes sufficiently severe that I can no longer deal with them in my clinic at my level, then they are referred to treatment. The key overall is that you have to move patients to seek help. They have to be aware of what the problem is. They have to be aware of what my concerns are. They have to be aware of what my expectations are for their change in behavior. They have to be aware of the consequences of them either complying or not complying. Basically, I expect my patients to be responsible adult individuals. Many times, as I've talked about previously in this discussion, when people come into my clinic, they don't really know that they've got a drug problem. They're just doing what they've been doing for a long time, and it's kind of getting a little bit out of hand. And they don't really realize that there's an issue here. Once a person has been informed of what the problem is, they either are willing or unwilling to address the issue. And that's really particularly true of a patient who has been to a formal treatment program, who has been through a 28-day treatment program, who has been to intensive outpatient treatment, or has been through a court-mandated DUI program, or has been put in jail and has been put through a drug rehab program. At that point in time, they have been formally and usually pretty thoroughly educated as to what the problem is, and at that point, their choice is whether they're going to be willing or unwilling to address the issue. And my approach is, if they're willing, I'm willing to help them. If they're not willing, I'm not. And in many cases, if they're not willing to adhere to my treatment protocols and to the boundaries that I have in my clinic, I just remove opioids and other controlled substances from their treatment program if it's a pain problem. If they're on a buprenorphine or a substitution program for their addiction and they continue to be non-compliant, I refer them to more intensive treatment, either intensive outpatient treatment or inpatient treatment, depending on the severity of the problem. But I don't continue to condone non-compliant behavior. You know, it's up to that particular individual to decide whether they're going to comply or not comply. It's patient choice and patient responsibility. I rarely discharge patients from my practice, but I frequently modify their treatment plan in a way that they find unacceptable and they leave my practice. And I'm okay with that. Everybody has to choose their own level of concern, their own level of tolerance, their own level at which they refer patients otherwise. You know, it's difficult. You know, how many times do we do liver transplant on actively drinking alcoholics? How many times do we replace the mitral valve in an IV drug abuser who keeps coming in with endocarditis? At what point does the patient begin to accept responsibility for their ongoing choices regarding inappropriate drug use as defined by me? That's a question we all have to answer on a daily basis. Thank you.
Okay, thank you so much, Dr. Hunt. All right, the next, you've gone through all these, right? We've put up Dr. Hunt's phone number and address here at Coastal Spine and Pain. And also we would like to see if anyone has any questions that you can type into the dialog box. And Dr. Hunt has a few more minutes. He'd be happy to answer those questions. So we'll wait for a few minutes if there are some of you who'd like to ask a question. I know he covered a lot of material. We'll wait just a few more minutes. Also, don't forget to do your evaluation so that you can get credit and your certificate. We'll wait just a couple, maybe another minute. Okay. We're trying to find your question here. Several of them. Thank you so much. Can you see it?
The first question I have is, what is the drug that I feel would revolutionize the pain industry? That is buprenorphine. It's the medication that's in Suboxone. It's basically an opiate agonist-antagonist drug that has a entirely different side effect and pharmacologic profile than the standard opiates that are used. Buprenorphine, as I said, is 20 to 30 times more potent than narcotics, than morphine on a milligram per milligram basis. It has very low respiratory depression potential. It does not produce much euphoria. It does not produce a lot of problems with suppression it does not produce anhedonia, I guess would be the best way to put that, like many narcotic drugs do. The major side effect that buprenorphine has is it does produce significant physical dependence and has to be tapered gradually. But overall, a person who's on buprenorphine operates at a much higher functional level with many fewer side effects than a person who is on hydrocodone, oxycodone, or morphine. In my pretty extensive experience, we have many patients in my clinic that have been transitioned to that drug off of standard opiates, and as almost universally, they do much better.
For those of you who are still on, which is most of you, there still are a few more questions Dr. Hunt is going to answer.
The question is how do you integrate non-medical modalities such as mindfulness into my practice? I personally don't have those facilities available to me in my clinic. I'm largely a buprenorphine medication management physician. That's my part of the role, but I do have an extensive group of providers in my in the Jacksonville area that I refer to, like Lakeview being one of them, who provide things such as IOP and more extensive treatment for addiction. I also use 12-step programs and things like Christian-based recovery. Yeah. And I also have Celebrate Recovery. Excuse me, I'm blocking there for a moment. It's a factor of being old. I also have a wide referring network of clinical psychologists that I use, as well as some psychiatrists that I use to treat comorbid anxiety and depression. Mindfulness is, I have a colleague in the local area who does a lot of mindfulness training, and I use her as a resource as well.
Also at Lakeview, part of our wellness program incorporates mindfulness.
Right. I like facilities such as Lakeview that have a comprehensive approach to that, and they send me quite a few patients to manage the medication management, or the medication-assisted therapy portion, and they handle the recovery / skill development. As I said before, the challenge with addicted patients is developing a new set of skills. Patients who come into me that are having problems with addiction is they do not have a set of life skills that allows them to deal with the normal pressures of daily life without the use of drugs. If you take away their use of drugs, you've taken away their primary coping mechanism, and what that individual has to learn is a new set of skills that allows them to live life comfortably without the use of drugs. That's a fairly intensive long-term longitudinal process. The standard term for that is, quote, recovery, close quote. And that really is what people that are trying to treat addicts are doing, is giving them a new set of skills. That's what you get in 12-step programs. That's what you get at a place like Lakeview. That's what you get from a good addiction therapist. Okay, I think that's all the questions that we've gotten. Spelling for buprenorphine is B-U-P-R-E-N or P-H-I-N-E. Google Suboxone, S-U-B-O-X-O-N-E, or Zubsolv, that's Z-U-B-S-O-L-V.
You guys have some great questions. Anyone else?
Treating pain, that's, we've only got a little bit of
Just so you know, the box on our side that we can see is very small.
Trying to scroll through and make sure that I haven't missed anything here.
Does that look like it?
That looks like it.
Okay, thanks everyone for participating, and please complete your evaluation, and you will be emailed your certificate, and you'll be receiving an email from us very soon about part 3 of the SBIRT training. Have a great day.